As global populations age and obesity rates continue to climb, the intersection of these two powerful risk factors is quietly fueling a surge in cancer cases among older adults. While both aging and obesity independently elevate cancer risk, their combination acts synergistically, creating a biological and public health challenge of enormous scale. This convergence is not simply additive, it is amplifying cancer susceptibility in ways that threaten to overwhelm healthcare systems, outpace current screening and treatment strategies, and reshape the future of cancer epidemiology. Aging itself is the strongest known risk factor for cancer. Over time, the body accumulates genetic mutations, experiences declines in immune surveillance, and undergoes chronic low-grade inflammation, all of which create a fertile environment for malignancies to develop. At the same time, obesity introduces its own carcinogenic processes, such as elevated insulin and IGF-1 levels, hormonal imbalances, and systemic inflammation. When these two conditions coexist, as they increasingly do, the result is a state of heightened vulnerability, where the body's defenses are weakened and cancer-promoting signals are amplified. This double burden is especially concerning because obesity among the elderly is more common than ever. Unlike earlier generations, today's older adults have often lived with excess weight for decades. Long-term obesity causes cumulative metabolic and cellular damage, including DNA instability and oxidative stress, both of which compound the effects of aging. For many older individuals, this means not only a higher risk of developing cancer, but also a greater likelihood of more aggressive disease and poorer treatment outcomes. The types of cancer most influenced by this dual burden are among the most common and lethal. Postmenopausal breast cancer, colorectal cancer, endometrial cancer, pancreatic cancer, and liver cancer all show stronger associations with both aging and obesity. In women, excess adipose tissue becomes the body's main source of estrogen after menopause, which can drive estrogen-sensitive cancers. In both sexes, insulin resistance, frequent in older adults with obesity, stimulates pathways that favor tumor growth and metastasis. Meanwhile, the aging immune system, already declining in function, struggles to contain or destroy these abnormal cells once they begin to proliferate. What makes this issue even more alarming is how underrecognized it is in both public and professional spheres. The elderly are often not the target of weight management interventions, either because of assumptions about diminished life expectancy or the misconception that weight loss in old age is either impossible or potentially harmful. This leads to missed opportunities for prevention. Yet research shows that even modest weight reduction and physical activity in older adults can reduce cancer risk, improve metabolic health, and enhance immune function. Treatment is another critical challenge. Older adults with obesity are often undertreated or excluded from clinical trials. Oncologists may hesitate to use standard chemotherapy protocols due to concerns about toxicity, drug distribution in adipose tissue, or comorbid conditions. Yet undertreatment can lead to worse cancer control, while excess fat tissue may mask the severity of disease on imaging or delay diagnosis due to vague or atypical symptoms. In this demographic, cancer is more likely to be discovered late, more likely to progress rapidly, and less likely to be managed aggressively, particularly when age bias or weight stigma enter clinical decision-making. From a systems perspective, the healthcare infrastructure is ill-prepared for this convergence. Cancer screening guidelines often stop at age 75, assuming diminishing returns with older patients. But this fails to consider that a healthy 76-year-old with obesity may have a longer life expectancy than a frail 70-year-old and may benefit significantly from continued surveillance. Similarly, lifestyle interventions are rarely adapted for the unique needs of older populations, despite evidence that targeted exercise, dietary modifications, and weight management programs can be both safe and effective well into the 8th or 9th decade of life. This looming demographic shift demands urgent attention. By 2050, the number of people aged 65 and older is expected to double globally, with a significant proportion living with obesity. The combined cancer risk in this population will not only drive up incidence rates, but also dramatically increase healthcare costs, caregiving burdens, and mortality. If we do not act now to mitigate this trend, we may face an era in which aging and obesity-driven cancers become the defining feature of oncology in the 21st century. Addressing this crisis requires more than individual behavior change. It requires age-inclusive public health messaging, medical training that recognizes the complexity of treating older adults with obesity, and policy shifts that prioritize preventive care across the lifespan. Older adults should not be written off or excluded from cancer prevention strategies. Nor should obesity be treated as a secondary concern in aging populations. Together, they constitute a powerful and dangerous force, one that will determine the future shape of cancer risk and mortality if we continue to ignore it. The double burden of aging and obesity is not just a statistical inevitability, it is a preventable and modifiable risk. But only if we begin to treat it with the seriousness it deserves.